and welcome to our EMS monthly lecture series. We're so excited to have you with us. My name is Ashley Balakis, and I'm one of the EMS outreach coordinators at Children's Hospital. And we have some awesome lectures for you today. We've got Callie Searly also with us on. She's another one of our outreach coordinators. And then Stacy Casada, who is our EMS for Children program manager and who helps us host these. So we thank her so much for all that she helps us do to get these going. Have some exciting announcements for the end of the lectures about our new online platform, education platform that we've just gone live with at Children's Hospital. It's got some amazing content already on it. And then we will be eventually switching this series over to that platform. We're hoping by next month, if not by June. So at the end of the lectures today, I will come on with some information on how you can set up your profile and go ahead and get logged into that. And you can go ahead and see what opportunities are already available. But we'll do that at the end. So stay tuned for that. We have two awesome lectures today. We're going to kick it off with Dr. Maria Mant. She's our fearless leader, our EMS director for Children's One Flight Team, as well as for Roar Fire, and just a major expert in all things EMS, and keeps us all up to date on all the changes. And she's going to do CPR and PALS, an acronym update. And then after that, we'll do a quick little break, depending on what time it is. And then we have Dr. Nate Jameson, who's going to be doing some burn injuries and inhalation injuries. So that will be the second lecture. So I will go ahead and kick it over to Dr. Maria Mant. Thanks,
Very
Maria.
good. Thank you, Ashley. That is quite the introduction, and makes me a little nervous to be called the expert in all of this. I don't pretend to be the expert in all of this, but this is one area in which I have a special interest and have lectured on quite a bit. So let's get going on this topic. I'm going to talk to you today about CPR and the PALS changes that have been recommended over the past year. And hopefully have time for some questions, but I'd like the record to show that it is after 9 o'clock and I tend to be verbose. So we'll see how much time I take up. So here's a sad reality that you may or not be aware of, and that is you all are called somewhere in the US to a pediatric arrest in progress every 75 minutes. And there's some very common thoughts that I think most of you probably think about as you're getting called to these scenes. And what I want to emphasize is not only are these feelings normal, but they do impact our ability to perform. Our ability to perform at our peak as providers. And this is something that affects all of us. And so as we go through the talk today, I want to focus on things that we can do as providers to impact the care we give on individual provider levels. But then, try to bring home to you as well that we need to care for ourselves and the secondary trauma that we all feel after being called to a scene like this. When we look at the pre-hospital data, we know that you all are the first point of contact for over 7,000 pediatric arrests per year. And unfortunately, bystander CPR is only happening in about just under 40% of these cases. And that, of course, depends on the area in which you live. But this is one of the big reasons why the survival to discharge rate is so low and has remained so low for so long when children arrest outside of the hospital, despite 25 years of improvements in the field. And by that, I mean the introduction of CPR feedback devices, increased research on both technique and drugs and all of that. We have seen a stagnation in improvement when a child arrests in the field. And we begin to ask ourselves, is there really anything that is going to change this rate? Now, there is hope when we look on the in-hospital cardiac arrest side. And as we move forward, we really hope that some of these advances on the in-hospital side can be moved into the out-of-hospital setting as well, although that may prove to be quite difficult. When we look at the past around 15 years on the in-hospital side, we've seen an almost doubling of the ROSC rate, just under doubling of the survival to discharge rate. And even when CPR is quite prolonged on the in-hospital side, there is a 12% survival rate, and 60% of those actually end up having a favorable neurologic outcome. When we drill down to see why those impacts have happened, the literature would point to 3 primary reasons. That is an emphasis on high quality CPR. And I see that as being translatable to the out of hospital setting. A robust debriefing program, which again, I see as translatable to the out of hospital setting. And then advances in post-resuscitation care. Now you may be thinking to yourself, wait a minute, we call this progress, but we still see fewer than 50% of kids who arrest in the hospital survive. And you'd think that with the loads of technology available that we could be doing better than even that. Why haven't we seen such an improvement on the pre-hospital side? And then why does the AHA seem to recommend the same darn thing every year? For those of you who follow the AHA and PALS guidelines closely, there's been the same primary emphasis since 2005. And that is those same 4 core principles that I'm going to talk about in the next slides. And they seem to just sort of rehash those same pieces year after year. I would encourage us all to think that maybe it's not because the science is faulty, but because we as providers, regardless of where you practice, in hospital or pre-hospital, we're doing some pretty simple things wrong. And those principles are much more easy in concept and theory than they are in practice. We're going to talk about some very straightforward objectives today. One, we're going to talk about CPR versus quality CPR. And I'm going to identify for you some common errors that we all make across all levels of care and the strategies to mitigate some of these errors. And then, as I mentioned at the outset, we're going to talk about some of the PALS changes and address whether or not these are applicable to our individual practices, and whether or not we can do it quite yet. Here are the hallmarks, I would argue, of a successful resuscitation in the pediatric out-of-hospital setting. One, we have to have agency level emphasis on frequent practice. And I'm going to talk about that further on in the talk as well. As you're rolling to the scene, having a discussion on the team of pre-arrival planning, role assignment, that pit crew level CPR performance. Number 3, concentrating on the basics, quality CPR. This is what we return to time after time as an indicator, the best indicator of ROSC. Remember the algorithm, specifically the AHA PALS algorithm. Acknowledge the secondary provider trauma that we all feel, and then having a robust debrief on an agency level. This is a lot to talk about, and so for the purposes of this talk, I'm really going to concentrate on numbers 3 and 4. Concentrating on the basics, performing quality CPR. So these are the 4 core principles that I mentioned AHA comes back to time and time again. Push hard, push fast is what we're going to start with. So as you all know, the AHA compression rate recommends 100 to a ceiling of 120 per minute with variable compression depths, depending on if you're talking about an infant or a child, and compression delivery on a firm surface. There's really no change, nor is there significant controversy in the most recent reiteration of the guidelines. The one thing that I do feel like is a steady progression in the AHA guidelines, is a movement toward hemodynamic-based CPR. And we see some reflections of that in the guidelines that came out last year as well. So the way that I like to frame this is to look at the compression depth recommendations specifically. We have a specific inch target in children. You'll notice that 2 inches for children is the same as the general recommendation in adults, right? This would therefore apply whether you are 40 pounds or 400 pounds, but I would contend that that is a very different effect if we focus on specifically 2 inches, depending on that size. That aside, let's drill down into the why it matters when we're talking about AHA principles. This was the one of the first studies really looking at this in live humans, but the original study of chest compression rate was published in the 1960s, and they looked then at a compression rate of 60. You'll notice that as time has gone on, we have honed in on this quite a bit, and the ceiling of 120 was placed in 2015 based on some observational studies really saying that when you get above a compression rate of 120, we lower our ROSC rate because now you have compromised target depth. There's no way that you can compress at a rate greater than 120 and hit those fairly modest compression depth targets. That, of course, will impact your coronary blood flow, which we know correlates directly with ROSC rates. So here we have that you see the gray is ROSC, the blue is no ROSC, and these are our greatest impactful rates. Now on the depth side, as I mentioned, we know that too impacts our ROSC rate. Compression depth and rate and survival in children has been studied mostly as a prospective observational realm. Now, that is a common thing when you're talking about resuscitation studies. It's hard to get a randomized control trial for something as critical as cardiac arrest. And our numbers in pediatrics tend to be smaller than what you see on the adult side. But this is a fairly robust study published 6 years ago now. Of kids in the ED or the PICU, and they picked a fairly low bar for success. They said if we get adequate compression depth, at least 60% of the total resuscitation time, we're going to call that successful. Less than 60% of the time, that's the unsuccessful group. And here's what they found. When you hit the 60% of the time hitting your depth rate, you'll notice that in all of the time points important to us, ROSC, 24-hour survival, survival to discharge, and good neurologic outcome, something as simple as hitting those compression depth rates drastically impacts survival rates. So again, focusing on the basics when you're talking about pediatric CPR makes a difference. This group controlled for all of the other confounders and was able to drill down specifically to compression depth. Now, how are we doing on a provider level when it comes to something like depth and rate? Unfortunately, we know that whether you're talking about the in-hospital or the pre-hospital side, we certainly have room for improvement. This was a large study across 101 EMS agencies in the United States, all of whom collected CPR quality data using CPR feedback devices. And what they did is they looked at CPR compliance as impacted by age. And what they found is in those younger age groups, the classically defined pediatric age group, we are much less likely to hit target rate and depth criteria. This is opposed to the older kids, teens, where it looks a little bit more like the adult data, where we're hitting those target rates and depth. So how can we as providers make an impact on an individual level to improve our technique. One of the easiest ways to do this is to use the two-thumb technique in infants, regardless of if you're by yourself or with another healthcare provider. And this actually showed up in the new guidelines as well. So if you're able to wrap your thumbs around and do the two-thumb technique in infants, we know that you are going to more consistently hit adequate depth and rate, that it doesn't impede your ventilation ability, and you're less likely to fatigue quite as quickly. Now, in pediatrics, in the child, the older than 1 year of age, the one or two hand technique is, we don't have any data to show one is more adequate than the other in live humans. On the mannequin side, there is some data that a two-hand technique in children is likely to lead to a slower rate of fatigue. Another strategy for improvement is to get yourself as high up on that patient as possible. In other words, putting your stretcher down as low as you can, so regardless of your height. This was an interesting study in which they looked at 124 compressors during simulated pediatric arrests, and they let the step stool use be a voluntary component for the compressor. But they found that regardless of your height, even for compressors over 6 feet tall, if you stood on a step stool, your compression rate and depth were more consistent and adequate. So translating that again to the pre-hospital setting, I would say this should further emphasize lowering the stretcher as much as you can, and getting yourself as high up on that patient as possible is going to improve your rate and depth. Now we have most recent data from just last year showing that CPR feedback devices really show the most promise, the most consistent promise. This was a study from last year that looked at real-time feedback and found that when we're looking at rate and depth specifically, with the device in place, we're hitting rate goals about 95% of the time. Without, we're only about 62% of the time. And similarly with depth, when you pay attention to the CPR feedback device and accommodate your depth accordingly, you're going to hit it about 73% of the time. Now, we don't see as big of an improvement with CPR feedback devices when it comes to full chest recoil or minimization of interruptions. I'm going to get to both of those later in the talk. But depending on the study you look at, CPR feedback devices may or may not play a role in that. We do know that much like a computer game, you are able to hit those targets more consistently despite a little bit of fatigue when you're watching and paying attention to what the device is telling you. We now have evidence from 2021, from a study in 2021, showing for the first time that CPR feedback device use is correlated with an increased survival, 27.4% without, 41% with. So this is the first time we've been able to see real correlative data in that regard. If you don't have a CPR feedback device available, capnography and following your capnography is the best next bet. The PALS update from 2020. Now this is looking again at how we can hemodynamically support our CPR, but they really recommend now that if you have a continuous invasive arterial blood pressure monitoring device in place at the time of the arrest, following your diastolic blood pressure is correlated with improved survival if you hit the targets I list here: a diastolic blood pressure of greater than 25 in infants, greater than 30 in kids. Now, for the vast majority of us on this call, this doesn't apply. But for my CCT colleagues on the call, when you're doing an interfacility transport, you may have this device in place. And now there is support through PALS to say this is the diastolic blood pressure is a good way to titrate your compression quality. Let's move on to minimizing interruptions. So this is truly the holy grail of ROSC attainment. And we know that the more we stop our chest compressions, the more we interrupt our quality CPR, the lower our coronary perfusion pressure is over time. And what happens when we have lower coronary perfusion pressure is we don't attain ROSC because the heart is not getting what it needs to survive. The AHA recommends that we maintain a chest compression fraction of at least 80%, and that the hands-off time is less than 10 seconds. This is not news to any of you. You know this, but putting this into practice is not quite as simple. I love this AHA graph because I think it illustrates quite well what happens when we interrupt frequently. So these blue lines that you see here, these vertical blue lines, those represent the compressions. Here represents a pause. Imagine this as your 15-2 in a pediatric resuscitation. What we're looking for here is a good aortic pressure and the coronary perfusion pressure we need to hit in order to perfuse that heart, right? So this is the goal. The coronary perfusion pressure goal is this red line. We finally hit enough aortic pressure in our compressions when we're nearly done with our compression cycle, right? So by the end of this compression series, now we're adequately perfusing the heart. What this should illustrate to you is the more you pause, the less time the heart is perfused, which then translates into a lower likelihood of ROSC. This, unfortunately, is quite common when we look at pediatric resuscitations. This one study here looked at in a tertiary care emergency department. So a group of folks who sees only pediatric patients doing their pediatric resuscitations. And what this study found was that there were 178 total minutes of interruptions and 650 total minutes of CPR for a chest compression rate fraction of 73%, so below the AHA recommendations. They found that a full 27% of the time, there were no chest compressions being delivered at all. And a third of those interruptions lasted greater than 10 seconds. So even in a setting in which those folks certainly know the recommendations, putting that into practice is much more difficult. Similarly, when we look across centers, a multi-center trial of simulated arrests, even then we're seeing pauses a good amount of the time for longer than desired. Interestingly, that multi-center simulated study, they found that the only thing that improved pause duration was a good leader and good communication during the resuscitation. These are things that the American Heart Association have been saying since 2010, but it doesn't mean we're good at it as providers. When we look at what are truly the big players in our causes for pauses, as you might expect, intubation attempts are really the big piece of it. So this was video review, and you'll see that we had a good chunk of the pause for pulse checks were too long, rhythm check lasted too long, and over half the time, intubation attempts lasted too long. But when you look at the total time, the pause duration was certainly the longest during intubation attempts. This study had 51 patients with intubation attempts with 84 total possible attempts, and the median pause time was 18 seconds per attempt. This adds up in a big hurry. So of course, now this begs the question, if we choose to intubate our patients during CPR, are there strategies we can use to minimize the compression interruption? This study looked at the concept of, well, maybe we should just do continuous compressions during our intubation attempts. What we see is that is not necessarily the panacea. The overall first attempt success rate was only 47% when we do continuous compressions with a median of 2 attempts per patient. We know that the more you instrument a child's throat, the less likely you will be successful with each attempt. Successful intubation without CPR interruption was 41%. Successful intubation with CPR interruption was 63%. So what we have to do here is essentially pick your poison, right? Either you have a lower first pass success rate, which again will decrease your likelihood of successful intubation at all, or you suffer more pauses. Another concept that has been examined is perhaps video laryngoscopy is the answer to all of this. Now, in adult cardiac arrest patients, you can find the answer you want to find, I think is the way to state it. There is conflicting data across the board to say whether or not this makes a difference. Some say there's no difference in first pass success rate regardless of the modality you use when you're talking about experienced intubators and paramedics. But other studies say that you're going to see a higher first attempt success rate if you use VL over DL. You'll notice that 78% versus 70%, those are both lower than what I would hope to see overall anyway. But if we then look on the pediatric side, there is scant data at best. And virtually all of it, actually not virtually, all of it is mannequin study based. And so I think the only true conclusion we can say is that there are many pediatric mannequins saved by VL compared to DL with continuous compressions, but we can't really make definitive conclusions beyond that. Others have asked, is the answer supraglottic airways? This was the most robust study to date, and it looked at adult out-of-hospital cardiac arrest, comparing directly supraglottic devices to endotracheal tube intubation, 27 agencies, 3,000 patients. And what you can see is that there is a significant favorable neuro outcome with SGAs over endotracheal tube intubation. Now, there again have been similar studies done looking at other comparisons, bag mask ventilation, for instance, which I'm going to go into next. But there is debate surrounding this on the pediatric side as well. Lastly, the question became, well, should we just stick with bag mask ventilation, forego all that other stuff and just stick with bag mask? There's no strong evidence linking intubation to a survival advantage in the CARES registry. And this is probably the most robust study that we have. Now, of course, this is retrospective data, which carries its own set of difficulty. But the numbers here are strong. 1,700 pre-hospital pediatric cardiac arrest cases, over 405 pre-hospital agencies. And what they found was that when you have bag mask only and compare it to endotracheal tube intubation in the throes of a pediatric cardiac arrest, bag mask doubles your survival rate to discharge. The argument here is that when we are worrying about placing plastic in tracheas, it distracts us from the basics. It distracts us from doing quality chest compressions, from concentrating on adequate oxygenation and ventilation. And so if we instead focus on the basics, we actually are doing better by our patients. And the American Heart Association has acknowledged that. The 2019 focused update said, bag mask ventilation is certainly reasonable compared to advanced airway interventions in the management of a pediatric arrest. I would encourage you all to think of things in this way. Both adult and pediatric pre-hospital cardiac arrest data shows that intubation is not specifically associated with improvement to survival. And intubation may not always help. Why might this be? We know that once we get that plastic in trachea, we as providers breathe a sigh of relief, and now we're more likely to hyperventilate our patients. We know that we have a decrease in our chest compression fraction because even these brief pauses, which tend to be numerous when you're talking about intubating a pediatric patient, that can impact our ROSC rates. We know that, again, concentration on something like plastic in tracheas results in delayed fluid and epinephrine administration, again, saying that we're not focusing on the basics. And there is some physiologic argument that intubation in and of itself, even under optimal conditions, may have a detrimental mechanistic effect on our patients. As you can tell, there is significant debate about all of this. I'm part of a working group with the National Association of EMS Physicians putting together a formal position paper for airway management in the pre-hospital setting for children. We are close to completion of this position statement, and I would expect that it will be published by the end of this year. So please keep your eye out for that. And hopefully we can have more guidance in the pre-hospital setting for airway management as it pertains to cardiac arrest. Now, if you do decide that intubation is the right thing for your agency, or if your medical directors have decided that it's the right thing for your agency, the American Heart Association has said that please choose a cuffed endotracheal tube over an uncuffed endotracheal tube when you're intubating infants and kids. This is similar language to what was used previously, but a bit stronger. Similarly, now they're saying, please do not use cricoid pressure. It does not decrease your risk of regurgitation. It is reasonable to use some cricoid manipulation to improve your view, but should not be a means of controlling aspiration or anything like that. The critical component here is if you choose a cuffed tracheal tube, you must be able to check that cuff pressure and keep it within range of 20 to 25 centimeters of water. We know that quite frequently, especially when you're talking about the varied elevations in our region, this cuff pressure can change drastically in children and result in quite quickly strangulation, suffocation of that mucosa. So how can we as individual providers improve our interruption rate? Besides the airway issues that I have talked about, other things you can do is have those fingers ready. If you have enough providers on scene, have somebody keep their fingers on the pulse the whole time during compressions and during the pause, so you're not fumbling around trying to find whether or not you have a pulse during your pulse site. Choose a pumper, right? Don't choose something like a radial pulse. Choose a femoral, choose a brachial, choose the umbilical if that's the situation. Here's a big one. Practice certainly makes perfect. This was a really nice study looking at standard training. So we know that nationally, most agencies do about 1 pediatric cardiac arrest training per year. And so how does that compare to doing it shorter amounts more frequently? So the intervention group, this group did CPR for 2 minutes on mannequins once a month with a feedback device in place. And they looked at 3-month testing of how your CPR performance is, with the goal of how many of those folks hit 90% AHA compliance during testing. They found that for those who trained annually, they hit 90% AHA compliance in a testing scenario less than 20% of the time. This compares to the group who was doing it once a month, but for short little spurts. They hit CPR compliance of 90%, 71% of the time. So maybe you're thinking, having this thought process of, we're gonna just hit pediatrics hard once a year. That's not the way we should be thinking about it. Rather than doing a 4-hour haul of an annual training, do 2 minutes of CPR on a mannequin with feedback once a month, and you're going to do more good for your patients over the long haul. Now, we actually instituted this philosophy within the Children's Hospital Emergency Department back in 2017. We now have a schedule in which twice a week, twice a day at shift change, we are doing CPR. We're doing some sort of CPR scenario with the team for practice. Short duration. The whole scenario lasts less than 10 minutes. And you can see that when we then looked at our survival rates for children actually coming in arrest, we had a drastic increase in our survival rates. So best practice strategies when it comes to minimization of interruptions. Choose your airway modality wisely. I would encourage you all to concentrate on well-performed basic strategies, and that is much more likely to have a positive impact on ROSC rates. Be ready for your pulse checks. If you can afford it, if you have the manpower to afford it, somebody sits on that pulse and that's the only thing they're doing. Highly impacted by team leadership. That communication piece is much more robust if you have somebody who can stand back away from the hands-on resuscitation and do things like setting clear expectations for the team, being decisive about next steps in the resuscitation, and running that debrief afterwards. Lastly, practice. Short and recurrent practice is much better than hitting it hard once a year. We're going to move on to allowing full chest recoil. What is this? Well, in a normally functioning heart, chest recoil is equivalent to the diastolic phase of that heartbeat. This is important because the diastolic phase is when you have reperfusion of the heart, feeding that myocardium the oxygen it needs to survive. And this is your preload phase, which fills up the heart and impacts how much is going to be pushed out. Obviously, if we're hanging on the chest, you're going to have a higher residual intrathoracic pressure, and this is going to decrease the coronary perfusion that happens, the subsequent push out of blood that happens, and the feed to the brain that happens. Unfortunately, we see that folks are hanging on the chest a good 25% of the total arrest time. The biggest player in this is rescuer fatigue. We know that once a resuscitation has been going on for greater than 5 minutes, once a compressor has been on the chest for greater than 5 minutes, you have significant you have significant reduction in chest recoil. You're hanging on the chest. This is an aerobic sport, doing chest compressions, and we get tired more quickly than we appreciate. So avoid rescuer fatigue. Make sure you are rotating out at every 2-minute interval. Use that step stool. That too has been shown to improve chest recoil, lowering the pram. CPR feedback devices, like I mentioned, show some promise. There is one lone study out there showing something interesting, and that is if you lift the heel of your hand during the release, keeping your fingers in place so you don't lose your spot on the chest, that too can have an impact on full chest recoil. I'd like to focus on the hyperventilation piece for a while. This is the fourth component of what the American Heart Association has focused on for years, and with good reason. We know that hyperventilation impacts it increases the residual intrathoracic pressure and impedes venous return, much like hanging on the chest, much like not allowing full chest recoil. There is a concern that this can cause air trapping and barotrauma and may increase the risk of regurgitation and aspiration. Here is the pictorial way to show this. When we have hyperinflated lungs, what you're doing is adding more pressure and compressing your SVC, your IVC, and your heart, right? This is impacting cardiac output. How are we doing as providers across the board? I would say this is the most common thing that we do. Oops, there we go. And it doesn't matter if you are in the field or in the hospital, we are really bad at not hyperventilating. This was a video review in a tertiary care pediatric ED, and they found a couple of things. One, even though what we say that we are doing 15-2 before airway placement, we're not. We think we are, but we're not actually getting good coordination. They found that there was a appropriate choreography of 15-2 in only 40% of the time. When an advanced airway was in place, we really hyperventilated. Ventilation was within targets only 23% of the time. A similar study found similar things. We're too slow, only 11% of the time. We're way too fast, to the tune of 30 to 40 breaths per minute, nearly 80% of the time. And hitting that previously deemed just right Goldilocks rate per minute, only 10% of the time. So here is where the American Heart Association made a really big change with the 2020 recommendations. You'll remember that previously, in respiratory failure, we were to be giving 1 breath every 3 to 5 seconds, and then that changed with cardiopulmonary failure, 1 breath every 6 to 8. The new change for 2020 says we're going to standardize this rate to 1 breath every 2 to 3 seconds, regardless of whether you are in respiratory failure or cardiopulmonary failure. It is the same. And this has been the mic drop moment for the American Heart Association, and I would say has generated the most passionate discussion within the field. I'd like to walk through this a little bit with you. The American Heart Association made this change based on this study, this multi-center study done in 2019. It was a study of 52 pediatric patients ranging from infant to 18 years old. And all of these kids had cardiac arrest events in either a PICU or a CICU. 60% were in the PICU, 40% were in the CI. All of these kids had monitors in place at the time, and so that allowed for a robust review and parsing out of confounders. They found that the first documented rhythm was either asystole or PEA in 17%, VFib, VTach in 9%, and a good chunk of them bradycardia with poor perfusion in 3/4 of the kids. No patient received the ventilation rate within the American Heart Guidelines, the previously set American Heart Guidelines, right? So that 8 to 10 goal, not a single patient was ventilated within that target range. Again, illustrating to all of you that this is not just a pre-hospital issue. Even the best of the best in pediatric facilities, they all hyperventilate. But here was the interesting thing that played out. When they hit ventilation rates that were higher, not as high as 40, which is the most common rate seen, but kind of that middle ground, it was associated with a 5-fold increased rate of survival. Now, that doesn't mean that hyperventilation is no longer bad. Respiratory rates greater than 35 were uniformly associated with a decrease in systolic blood pressure and a decrease in survival. So again, finding maybe there's a different Goldilocks range than we initially thought. Now, as you would imagine, this created a lot of conversation because we've been doing it the prior way for years and years and years. So it seemed a little disconcerting that the American Heart would make a change based on one pretty darn small study. I want to go through with you the arguments for why folks are saying we shouldn't make the change, and the American Heart's response to why they decided to go forward with the change. So what I have been hearing on the don't change it side was that when you look at the population, both the fact that they were ICU, PICU, and CICU, that this first documented rhythm is much different than the first documented rhythm that we see in the pre-hospital setting. The AHA response to that, and actually the response from the authors of that study, will tell you that the study statistics controlled for that initial rhythm. And so, yes, they were monitored highly, and it was a different initial rhythm than what we might see in the field, but the statistics were able to parse that out. It's a not typical population because they had monitors in place and they had preload controlled. In other words, they already had a good volume, were normal volemic prior to their arrest, unlike the highly uncontrolled setting of the pre-hospital field. But the AHA would argue, and I would argue too, that this would allow you to say all of those other pieces, those confounders, we can take those out as problematic and focus solely on the ventilation rate as what was impactful, right? So another way to say this is, if I did not have the monitors in place, if I did not have volume controlled for, and I am saying that it's the ventilation rate that made the difference, is it really the case, or is it because of these other pieces that complicated the overall picture? Another argument is that animal models from the 80s piglet studies showed that hyperventilation rates, including rates 20 to 30, were linked with death. And the response to that from the AHA is that this is the first human study. and they are placing more credence in a study of human children than they are placing in piglets. Another important component of this is that those studies, those recommendations previously were extrapolated from adult data, extrapolated from animal data, and applied to children. Initially, when the ventilation rates were being recommended, the American Heart Association had said, we don't have any pediatric data to guide us. So for the ease of teaching, we are going to say to do the same thing in children as we say in adults. Another argument is that a single small study should not drive a change in decades-old recommendation. I kind of hit on this already. The original rates were recommended to unify pediatrics with adult recommendations and not based on any pediatric data specifically. And then the last hypothetical concern is that this may worsen the frequency of hyperventilation. And the argument from the American Heart Association and from the authors of that study with whom I spoke, they say, look, we're already hyperventilating 100% of the time. It's still bad. We're not saying that hyperventilation is no longer bad. We're still saying we need to slow down, but slowing down to adult rates may not be the answer. We've never defined specifically what hyperventilation means in children. And rather than saying it is above 8 to 10, maybe a better definition is above 30 to 35, or above 30, yes, above 30 to 35 in kids. To further that argument, we know that children usually go into cardiac arrest because of a respiratory etiology. So why are we not feeding the respiratory engine to a degree that helps them without increasing the intrathoracic pressure? So regardless of, let me step back. This was a hotly debated topic within the Denver metro area. And as we look to put out recommendations for the Denver metro protocols, because of the degree of debate and unrest, we have opted to maintain the current 8 to 10 breaths per minute as a recommendation for the Denver metro protocols, pending further studies. This, of course, is something that may be changed on an agency to agency level as per your medical directors and their read of the literature. And so for certain, you need to be thinking about having a discussion with your agency about whether or not you're going to make these recommendations for your particular area. No matter how you define hyperventilation in kids, it still happens and we need to try to avoid it. So what are some strategies for improvement? One, use the 2-person bag mask ventilation technique whenever possible. This has long been a recommendation. Greater than 10 years ago now, this study was done, but it takes more mental brain power than you would think to do the concentrate on getting a good seal and troubleshooting when you don't, and then concentrating on the squeeze rate and depth of compression. One finger technique is something that has been discussed mostly in the adult literature. When we put our whole hand around that bag, we tend to squeeze much more significantly, which does more, which tends to hyper expand that chest, as opposed to doing just one finger. We don't squeeze the bag quite as much, which can impact how much you hyperventilate or hyperexpand. You can count out loud, use a metronome or ventilation timer, and then, as always, using your capnography as a guide. So in the last few minutes here, I want to talk about remembering the algorithm and a bit of the other change, which is a minor one. The 2020 PALS recommendations now say it is reasonable to administer the initial dose of epinephrine within 5 minutes from the start of chest compressions. This is just a doubling down, a clarification of the importance of epinephrine. This too was based on in-hospital PICU and CI studies, and which is what we see actually for the majority of recommendations made. And the emphasis here is because they saw that in these observational studies that there is an increased survival rate when epinephrine is given within the first 3 to 5 minutes of a non-shockable rhythm. And that for every minute of delay, they saw a decrease in ROSC. So again, emphasis on early epi is probably good. As I mentioned at the onset, acknowledging the secondary provider trauma of these cases is an important thing for us to do. Debriefing what you have seen as a treatment group, as well as a broader agency, impacts not only the survivor trauma, but also the improvement in CPR, in resuscitation going forward. So I'm going to put in a little bit of a shameless plug here. I'm the secretary for the Colorado chapter of NAEMSP, and we have proposed for MSAC next fall, for the fall, formerly called the Fall Physicians Forum, but we're changing it because we want to encourage providers of all levels. But our proposal for the Fall Forum is provider resiliency in the face of multiple stressors. And I think that this resiliency component, the secondary trauma component that happens is a piece of this. The provider resiliency components that we plan to discuss really look at what are the system and societal costs that providers on an individual level suffer, how that impacts family life, how that impacts your health, and how you can identify the danger signs in your colleagues and promote recovery at an agency level. And then how do we as individuals improve our own personal resiliency? So we would love to see all of you attend and look forward to presenting this at MSAC this fall. So in summary, there are very few things that can improve outcomes in pediatric cardiac arrest, but I would really emphasize to you all that basics make a difference. If you concentrate on the basics, you're doing the best by your patient. Good communication really impacts all components of quality CPR. We may not have a consensus on what the definition of hyperventilation is in pediatric patients, but when you do hyperventilate, it is deadly. Oh, I'm sorry, I just inhaled a bug. If you stick to the basics and do them well, you're most likely to save that pediatric life. And I would encourage you all to watch for alterations in your protocols because the PALS recommendations from last year have been impactful. This is one of my favorite quotes when it comes to thinking about pediatric resuscitation, and that is, if you think you're too small to make a difference, try sleeping with a mosquito. In other words, you may feel like your role in a resuscitation is small, but even those small things, the small things like focusing on how often you are breathing, those things make a difference. So you do have an impact, your role has an impact. And so thank you for doing even those little pieces well. That is it. I am happy to take any questions folks might have.
See what I mean? Great job, Maria. That was awesome.
Thank you.
Yeah, everybody, please feel free to type any questions that you have for Dr. Matt. That was just, I love that talk, Maria, because you gave the background of the why. Why is this so important with the truly up-to-date studies and data that's out there? But then you give the practical techniques, the strategies, the exact things that you can implement, and how basic some of these seem that make such that big difference. And so giving that how, I think, is so important and so powerful. So thank you for drilling it down to each level and each category and how it's so important.
Thank you.
Great job. All right, here's one, Maria. It says, suggestions on anterior or lateral pad placement, and can feedback devices be placed over pads?
Yeah, so that's a great question. The American Heart Association says that in infants, the front to back is preferred, but you can do it either way in the pediatric population. The feedback device over pads is something that actually we did do for quite a while in the agency that I help out with, and we found that it did work sufficiently. I would say that the benefit of having a feedback device, we certainly have the data now to say that the benefits far outweigh any sort of detractors when it comes to CPR feedback devices.
We are so excited for our next talk. We're going to have Dr. Nate Jameson. I see that you've shared your screen, so thank you so much for being prepared. Nate, I'll go ahead and have you. He's one of our pediatric emergency medicine physicians, new to us at Children's. So I'll have you go ahead and tell us a little bit about your background, Nate, and then kick it off. Thanks so much.
All right, you guys let me know if I am mumbling or talking too quiet. I do have a tendency to do that, so please let me know. But yeah, I am Nate Jameson. I am originally from Texas, did my training out in Columbus, Ohio, and came out here about a year and a half ago, but was in the Springs this past year and was only working part-time. So kind of gonna start my EMS teaching and everything up here right now. So hopefully get to see you guys a lot more over the next several years and get involved a lot more. And during this, please feel free to chime in, ask any questions. Please actually keep me updated on any big questions that are in the chat, and I would be happy to answer anything. So I was going to start with smoke inhalation and burns. Probably a little less important for the summer, but definitely still happens, especially with all the wildfires that happened last year. It seems like it would be something that would be pretty pertinent that you guys do see occasionally, and kind of to go over the big issues, the big differences for pediatrics compared to adults. So the big objectives for today are to anticipate, recognize any airway burns, evaluate the total body surface area for pediatric patients and manage appropriately, and then to recognize and treat carbon monoxide and cyanide poisoning. So we'll kind of start with the case. So you're called for an apartment fire. You find a 20-year-old female, her 13-day-old daughter. She has complaints of dizziness, headache, nausea. The infant is sleepy, not feeding very well, and has burns to the face and neck. You place both patients on 100% O2 via non-rebreather, and both have stable vitals. So happy to chime in if you guys want to, but also you can just think about it. So thoughts on differential, things that you would be preparing for, what treatments would you want to plan on, and what recommendations would you expect from med control if you called them and asked for any updates. And then also, how would you tell the hospital to prepare for these? So say you're 10 minutes out, you give them a heads up, what would you want to tell them to be prepared for? Let's kind of go into the smoke inhalation aspect first. So inhalation is kind of a non-specific term, but pretty much refers to any damage in the respiratory tract from heat, smoke, chemical irritants. Smoke can include so many different things. Kind of the most common are the ones listed up here: aldehydes, ammonia, lots of acids, all the hydrogen chloride, all those terrible things that you don't want to actually breathe in. And then a question for everybody is, how many patients with burns will have inhalation injury? And so it's actually about a third of patients with burns, with burn injuries will have inhalation injury. And I feel like that was higher than I had seen, and that makes me think that I'm missing some. And so definitely something to keep in the back of your mind. And these these airway burns, the inhalation injury, is responsible for up to 77% of deaths related to burn injury. So definitely not something to overlook. So what you should initially do when you first see them, obviously ABCs are always first. And then carbon monoxide poisoning should be presumed until you get either negative carboxyhemoglobin level on coax or in the hospital. But that's definitely something you should always expect. And we'll talk more about that later. And then early intubation is considered on any patient with suspected inhalation injury. Anytime you have burns to the face, the mouth, the oropharynx, anterior neck, and then of course singed nasal hairs or mustache or beard, that obviously raises the concern. Anytime you have carbon deposits on the lips, nose, mouth, and sputum, and then any kinds of respiratory distress, hypoxemia, hypoventilation, those are all very, very concerning and something you definitely want to intubate early rather than later. And just kind of show you pictures. Obviously, these patients are at high risk of airway compromise, airway burns, and so you definitely want to intubate them sooner rather than later. If you get to them and they're speaking right now, they very well may not be in the course of 10, 20, 30 minutes on the transport. And make sure to have a smaller tracheal tube ready as well. Very common that you already have inflammation, edema, swelling around the area, and you may not be able to get your standard ET size in there. Getting something in there is better than nothing, of course. So on these pictures, of course, you can see second-degree burns on the nose, on the lips. You see the carbon deposits all around the nose and the mouth. And this patient obviously has very severe burns all over the whole face, carbon deposits in the nose. Super high risk. Definitely want to intubate these as soon as you see them. And then just one to kind of pucker everybody up a little bit. If you haven't seen it, this is basically a pretty poorly burned airway, and you could tell you really can't see anything. Even with video, it's super hard to see in there. And if you can intubate before this point, that is obviously much better, much safer for the patient and under much more controlled situations. And you can see in that video too, there's carbon deposits all over, so it doesn't stop at the mouth. When they get aspirated, inhaled, it goes all the way through the respiratory tract. So what's the kind of pathophys of this? Why do we get such bad airway compromise? And a part of it is cilia loss. So all the cilia get burned with the heat of it. And then you can have sloughing of the respiratory epithelia. So basically you have the skin that kind of starts peeling off, just like a second-degree burn on the skin. That skin can kind of flake off and start obstructing your airway. You get white blood cells infiltration into there, and that obviously can make more edema. So basically think of it as kind of pus starting in there. And then once you start getting this debris, once you start getting obstructions, you get atelectasis, you get occlusion, either from the debris or just from the edema from the swelling. Then you get also pseudomembranes and bacterial colonization at 72 hours. So this definitely is not necessarily you're not necessarily going to see this, but something that you want to think about down the road. And this is still why it's very important to intubate early. And you kind of get these airway casts as well. We'll talk a little bit more about this next slide, but so these are basically just big plugs. It can be from mucus, it can be from epithelial cells that have already sloughed off and kind of causing obstruction. There's those white blood cells in there, so you can tell this is kind of basically a mix of pus and cast, and everything's kind of all clumped together. In addition, you can have fibrin, which is why some use TPA, probably not in the field, but once they get to the hospital, some patients do get TPA, which is to help kind of break up these casts, help us clear them and prevent further compromise. So things that you can look out for and things that you'll see in the field. So wheezing, ralls, decreased aeration, those are all worrisome. That to me would be an indication, if they weren't present before, that you would probably strongly consider intubation. Cyanosis is a late sign of decompensation, so I would not want to wait for that. Untitled CO2, of course, is always good. I'm assuming we're doing this for most of any kind of airway patients in the field and on the way in. But that's a very good indication of ventilation. It gives you a good marker, so something to keep track of. And then clearing the airway is important. And I know most of the stuff is not something you guys would be able to do. But, definitely suctioning, you can definitely do having the patient cough if they're old enough to kind of help clear some secretions. And humidified O2. I'm not sure if you guys are able to do that. I know a lot of the children's crew can do that, but even as simple as putting some saline into the albuterol reservoir that you could do can definitely help a lot, help clear some of those secretions and help moisturize everything. We can do CPT in the hospital. We wouldn't expect you guys to be doing that out there. And then pharmacologic is kind of where some of the fibrin cast comes in. I'm not sure if you guys have mucomist on the truck. I know some crews do, but I would assume most do not. But pharmacologic is probably not your, you only have them for 20, 30 minutes, so probably not what you're going to focus on. But things that you could do, mucomist, some people do inhaled heparin, and albuterol can help as well sometimes, kind of when you have that wheezing component of it, and to kind of help limit some of that, the spasm of the airway. And then another thing to consider too, burns are an added effect to exterior burns. And so something to consider, so you say you have 10% burns to the body, but a lot of it is associated around the face. Your first fluid bolus and initial resuscitation is it's going to be additive to that. So just keep that in mind, that feel free to you can give a little bit more fluids for airway burns, because you are losing, you have more insensible losses there compared to usual, and you have that edema as well. For you guys, upper airway burns do usually present within the first 24 hours, so definitely something you're going to see. Lower airway compromise and kind of more of the cast and those kind of things will come up later on, usually about 1 to 3 days. So not something that you need to focus on for the most part, but something to always keep track of. You guys have any questions with this? I probably ran through that a lot faster than I was expecting. We're going to go on to a couple different stuff. If you have any questions, please let me know. And of course, we're all adult learners, and supposedly adult learners need breaks. So I like to put in some of my travels. This is outside of Banff, Canada. Really great hike going up through this valley and kind of up around the ridge, and it was fantastic. Highly recommend it to everybody. All right, so let's go into more pediatric burns and kind of how they will differentiate themselves from adults for a little bit. So about 25% of burn hospitalizations are in children. So definitely something you'll see frequently. So I'm not going to go through all the skin breakdown, but the large function of the epidermis is regulation of temperature to prevent insensible fluid losses. And of course, that's very important in the patient that you have from the field. Say it's a cold night, there was a house fire, they've been out waiting for you guys for 10 to 15 minutes with the police officer until you guys get there. They're going to be pretty cold, and they're going to be more dehydrated than you expect, not only from the very dry air inside a house that's on fire, but obviously they are going to lose a lot of fluid from the skin, especially in the very dry climate in Colorado. And of course, they have thinner skin. So you say the parent comes out and she doesn't have very many burns, and you see the kid and it looks about the same, but they can actually have much more severe injury comparatively, because their skin is much thinner and much more sensitive. We'll also kind of review these. I'm sure you guys are pretty familiar with these. So first degree is very superficial. This picture here, kind of dry, red, painful to the touch, blanches with pressure, very similar to kind of first degree sunburns. Usually nothing we worry about. Those just heal on their own. We don't even count those as our total body surface area burned. Really what we start counting is anything second degree and above. And there is two, there's a superficial partial thickness and a deep partial thickness, which we'll sort of review here. So kind of that superficial is the pictures here. The skin is very red, blistered, moist, and swollen. It's very painful to the air and temperature, does blanch with pressure. So these are kind of the most common ones that we see, and I feel like the ones that you see as well. Here is a picture of the deep partial thickness, and they do differentiate themselves a little bit. It's kind of this kind of waxy white appearance here. They're a little more waxy. They do blanch. Sorry, they do not blanch. They can be painful. They cannot be painful. It's a little bit in between the second and third degree. The third degree is full thickness. It varies from waxy white to leathery gray to charred and black. It can look all the above, but very clearly this is different than what you see with the second degree. the first layer is already kind of been burned off. You have this very waxy white appearance, a little bit of charcoal up there. These are not going to be painful because there's not sensation to the skin. The edges, of course, maybe because you get kind of varying layers of burn, and it does not blanch. So this looks like, basically just a piece of leather over their skin. And all of these are definitely very concerning in the second and third degree, or what we would like to see in the hospital. So this is kind of just the main differences of the pediatric versus adults. You guys are probably more familiar with this. There is big differences in the head, in the pediatric patients. The heads are just relatively bigger, so you're gonna have to add a little more percentage for that. The one thing that I always kind of keep in the back of my head is the palms, mostly including the fingers, are about 1%. There's actually some will say it's just the palm without the finger. Some will say palm with fingers. But in general, if you kind of hold your hand up to burn, that's about 1%. You can kind of extrapolate from there. And in the field, your best guess is definitely good enough. But again, we're mostly worried about the second degree and above. We don't really care about all the first degree burns. I'm actually not sure, and maybe Marie can help me with this, if there is any kind of difference of traumas, trauma red versus level 1 trauma for percent burns. Our previous institution, we had differences, which it was good to let you guys know, but I'm not sure if we have that here. So things that you guys can do on the way in, remove any burned clothing and any jewelry, unless it's stuck to the patient. Obviously, if the burned clothing is stuck, which some of the newer fabrics can definitely do, kind of melt to the patient, you'd want that to just stay on. We wouldn't want you to worry about that. But then cover the wounds with a dry, sterile dressing. Can be sheets, it can be blankets, and don't put any creams or anything on there, which I don't think you guys were doing. Sometimes other hospitals will do that before they come to us. But basically, it's harder to look at initially look at the burn and to tell what stage they are and what we need to do about it. And then, of course, pain control as needed. Definitely okay to give IV narcotics, intranasal narcotics to patients that need this. Very, very painful, and it can obviously cause a lot of distress. So please don't be too afraid to do that. Big thing is to follow the blood pressures closely. Basically, the higher body surface area to weight ratio in kids definitely increases the fluid losses. They're much more susceptible to hypothermia, like we talked about, and anytime you get burns and inflammation in general, really, you get release of vasoactive mediators, leading to capillary leakage and pitting edema. And of course, this depresses your cardiac output. So you get all of that central blood, and that kind of goes to the periphery. You have less intravascular volume. And of course, your heart function is a little bit impaired with that situation as well, especially with most people, I feel like they're kind of baseline dehydrated as it is. And this just further complicates things. So definitely keep a close watch of the BPs and give fluids as appropriate. And of course, you guys are familiar with the Parkland formula, 400 mLs times the kilos times the total body surface area. And again, this is only second or third degree burns. And this is on top of the normal maintenance fluid, so just keep that in mind. You guys won't have to worry about this part for the most, but half is given over the first 8 hours, remainder over the next 16. You can use LR or normal saline. I think that's, these days, a lot of people are going more towards lactated ringers, but that'll kind of change. And you can definitely add dextrose for patients under 20 kilos, because they're going to have much more glucose utilization and they have less stores. Again, we had a protocol at our old institution. We kind of deviated from the Parkland formula a little bit, just for simplicity's sake. And so anybody under 20 kilos and had these certain criteria, we don't have that here as far as I'm aware. But just be aware that if they do recommend something like that over the phone, that different institutions may have this, and just kind of be a little flexible there. And of course, later on, we do the full calculation of rehydration and monitor the urine output. The goal is about 1 ml per kilo per hour. You guys shouldn't have to worry about that. So patients that should be transferred to burn centers, this is based on the AMERA burn referral criteria. And these courses can vary a little bit from place to place, but partial thickness, more than 10% of the total body surface area should definitely be transferred to a burn center. Anything that involves the face, hands, feet, genitalia, perineum, and any joints should definitely be referred. Any third-degree burns, any significant electrical burns, and then chemical burns is a little bit up in the air. Not every chemical burn needs to go, but definitely anything that looks concerning should go. And of course, any inhalation injury as well. Anything that's circumferential is kind of left up to the providers. In general, it's a referral criteria to a burn center, but if they're, pretty mild circumferential burns, they can be managed at a local hospital. Anything significant should be referred to a burn center for kind of specialized care. And of course, you should intubate if the total body surface area is over 40%. This is their recommendation, even if there's no facial burns, based that they're at high risk, and it'd be really important to get them intubated earlier. And make sure you use rock and ketamine or etomidate. You would want to avoid any hypotensive agents, again, for that blood pressure effect, and any depolarizing agents. Other considerations, you guys don't have to worry about this as much, but make sure they have their tetanus up to date, because that's definitely a possibility with non-intact skin. Most experts agree steroids have no role in burn patients. I've heard occasional stories of people recommending that en route, but something you probably won't have to worry about. And then of course, there's some other things like vitamin C, but you don't have to worry about that. Another mental break here out in Arches with my son's a couple years old, but he was super excited to go there. Let's switch gears a little bit and talk about cyanide exposure. Cyanide, so among the most rapidly lethal poisons known to man, which I thought was a fun little fact when I was putting this together. Many sources of exposure, of course, for us, the production of combustion of plastics, furniture glue, paints, fertilizer. Basically, I've seen stories of someone in a photography studio having their trying to save some paintings and got cyanide toxicity. Any kind of fumigation process can sometimes do it. Pesticides, up to random hair removal from hides. So if you guys are out in the somewhere in the city and they're doing that, you can definitely think about cyanide poisoning. So what is cyanide? It's found in bamboo sprouts. There's some natural sources up here, like even pears, peaches, and apples, which I thought was kind of silly. And then of course in sodium nitroprusside is there as well. And then laetrile, I'm not sure if I'm pronouncing that right, but it is naturally found in plants that are up there. And then it's actually falsely sold as a cure for cancer. And I have not seen it personally, but there is reports of people taking this something they get online and then getting cyanide toxicity from it. So kind of why is it so bad? So basically it blocks the transport of oxygen in red blood cells and inhibits the electron transport chain in mitochondria. So basically you can't utilize oxygen and you can't make energy for your body. And so basically everything shuts down. So it leads to an inability to add electron to oxygen and make ADP. And so you go from your normal aerobic metabolism to a purely anaerobic and very quick lactic acidosis. Again, everything just kind of shuts down. Because everything shuts down, you get a lot of clinical findings of it. I'll kind of go through most of it here. Unfortunately, a lot of it is all very important. Kind of the start of it is, headache, some confusion. You can get coma, seizures. Initially, you get tachycardic and hypertension, but then when everything starts to fail, you get actually bradycardia and hypotension based on when you get to them. You can get AV block. You can get dysrhythmias. For respiratory, it's the same thing. You get initially tachypnea because of that acidosis, but then when your lungs start to fail, you get bradyapnea, you get pulmonary edema, GI, you get vomiting, abdominal pain. Sometimes the board's question is an almond taste or smell. Apparently you don't really notice that most of the time, but you definitely can. Skin, the classic answer is that cherry red color of the skin and cyanosis. I'll tell you that most people don't present with that, but it definitely is possible. And then again, you can get other systems involved, just like renal, liver failure, rhabdomyolysis, kind of everything under the sun. And then one thing you may notice is venous blood may appear very bright red, basically because the oxygen is not being utilized. It looks like arterial blood. Symptoms can start immediately in IV exposure, minutes in inhalational injury for your house fires, and up to hours after dermal exposure. Here's the levels, which you guys probably won't be able to get in the field, but you know, 0.5 to 1 is mild, 1 to 2 is moderate, and anything over 3 is often lethal. Things that you should consider doing: routine tox screening, blood gas. Lactate is going to be a big deal. I'm not sure if you're able to do that in the truck or not, and coax as well. So coaximetry measures blood levels of oxy and deoxyhemoglobin, your carboxyhemoglobin, and your methemoglobin. And a routine pulse ox is going to show falsely elevated O2, again, because that oxygen is not being utilized. So it's going to show very, very high. But if you have any concerns for it, basically just assume that they do have cyanide toxicity. Empiric antidote treatment is recommended with any history of smoke inhalation in an enclosed area, soot around the face, and a GCS of less than 14 or any abnormal hemodynamics. Make sure you remove them from the source and any contaminated clothes, again, because the contaminated clothes can lead to further dermal injury and absorption from the skin. If you can, GI decon if there's any cyanide ingestion, because it's rapidly absorbed. So the sooner you do it, the sooner, the better it is. And just a single dose of charcoal. Multiple doses are not proven, again, because whatever is in there gets absorbed very quickly. I'm assuming most trucks have cyano kits. There's a couple different brands out there, but basically it works by direct binding of the cyanide, forming cyanocobalamin. Then it's subsequently excreted in the urine. The dose, you can do 70 milligrams per kilo up to 5 grams, which is the whole bottle. You do it over about 15 minutes. You can repeat once, but shouldn't repeat more than that. Basically, you can watch for hypertension. You can watch for allergic reaction to it, and then kind of a warning that it can lead to red membranes and red urine. So if you happen to see that, don't freak out too much. It does mess up your your coax. It messes up your labs, but obviously, saving the patient is top priority. There's another one out there as well, sodium thiosulfate. Works very similarly. It's a sulfur donor, and it detoxifies cyanide into thiocyanate. Hyperbaric oxygen actually, in one study, is shown to help a little bit. Definitely something to consider whenever you're talking to your admitting hospital and see if they want to consider it. Again, more in combination with the carbon monoxide, which we'll talk about. But basically, in combination with the cyano kits, it can help facilitate transport of the cyanide out of the tissue and improves your respiratory status and decreases the surge of brain lactate. So something to consider. This one is DC'd, as far as I'm aware, unless they have reversed that in the time since I've made this. Basically, it induced methemoglobinemia, but it was pretty toxic in certain patients, contraindicated in carbon monoxide poisoning, anemia, pregnant women. And so I think for the most part, it was not favored, and they got rid of it. Another mental break out in Yosemite. If you guys have not gone, probably one of my favorite parks. It was amazing. So let's do another case, kind of switch up our brains a little bit. So you get called for an 11-year-old female who's found unconscious at home with her father. GCS was initially 9, improving to 11 after a short assessment. Labs revealed a white count of 21, trip of 0.9, CK of 630, and carboxyhemoglobin of 37. Chest X-ray showing a right upper lobe infiltrate, and remainder is very normal. She's on 100% O2 with stable vital signs. So during transport, she's had repeated vomiting without much improvement of her mental status, so still sitting at that GCS of 11. Only responsive to painful stimuli, eyes open to pain only, and she is only moaning between episodes of vomiting. So again, things to keep in mind, kind of what is on your differential, what treatments would you plan on, what recommendations would you expect from med control, and then how would you tell the hospital to prepare for these patients? So this is kind of a pretty standard carbon monoxide poisoning. Kind of every member of the family gets sick at the same time, have kind of vague complaints starting out with headache, a little bit of confusion, and kind of further progressing from there. So where does it come from? Obviously, most common during winter and the cold climates. So lots of heaters make carbon monoxide. Very common in Texas during the last cold snap because people were doing propane heaters inside, and that can definitely contribute to it. Any kind of smoke inhalation, poorly ventilated flames or vehicles, and the classic example of someone with their car running in the garage. I've even heard stories of people in boats driving on the lake, and if the boat is designed kind of poorly, or they've kind of makeshift a component, a cabin on there, the draft can actually pull the carbon monoxide into the cabin and kind of have people pass out from there. So carbon monoxide diffuses rapidly across the pulmonary capillary membrane. It binds to hemoglobin 240 times more than oxygen, which of course leads to tissue hypoxia. And if you guys are familiar with it, it's a left shift on the curve. So complications, kind of like we talked about earlier, it's very vague symptoms, unfortunately. Headaches, malaise, nausea, dizziness, tachypnea, tachycardia, arrhythmias, and frequently misdiagnosed as a viral syndrome. And say you have 3 members of the family come into the ER at the same time, and they all have these vague complaints. A lot of people would say that it's most likely a viral illness and get them going home. The things that you really should worry about is kind of anything over this 21 to 30 cutoff here, and anything above that should have you very concerned for carbon monoxide poisoning. So basically anything above moderate headache, any kind of respiratory changes, any kind of altered mental status, and usually it's pretty severe if they have altered mental status, seizures, and coma. If there's any concern for it, basically the plan is to put them on 100% non-rebreather. Very severe complication, poisoning results in marked hypotension. It's lethal in high doses. You can have pulmonary edema. And so kind of this lethal arrhythmias, basically the carbon monoxide readily binds to myoglobin, and any immediate deaths in a house fire is usually attributed to cardiac arrhythmia, since it's very sensitive to hypoxia. You do get decreased cardiac output, you get free radical formation, and then kind of leading to neurologic changes. And actually you can have these changes that occur up to 28 days after exposure. So it can be something that you don't see right away. It can be a kind of a delayed presentation as well. The good news is you do get a slow resolution in almost all cases. You do have occasional permanent brain damage if you don't have that initial cardiac arrhythmia leading to death. But in general, patients do very well if they get to the ER or get to the hospital quickly. For you guys, kind of workup includes an EKG, and once they get to the hospital, plus minus cardiac biomarkers, and that's kind of if they have an abnormal EKG, if there's any history of heart disease, any evidence of ischemia, if they're very young or very old, or just for giggles like most adult ERs do. And then coax is important as well. Like we talked about last time, it measures 8 different wavelengths since the pulse ox is unable to distinguish between the oxyhemoglobin and the carboxyhemoglobin. And so again, you're going to get that kind of that falsely elevated level. Blood gas as well is going to reflect the oxygen dissolved in the blood. So it's also falsely normal, so you can't rely on that as well. One thing to remember too, and just kind of why I started with the pregnant patient in the very first one, fetal hemoglobin binds the carbon monoxide tighter and actually maybe 10 to 15% higher than the mother's. So definitely something to consider, that if the mother has carbon monoxide poisoning, definitely think of the infant as well. So treatment, obviously remove from the source of carbon monoxide, put them on 100% O2 by a non-rebreather. And then this is where the hyperbaric oxygen really comes into play. So you can see the half-life here, which is kind of a big difference. In room air, you get about 300 minutes. And so they're usually on, if they don't have 100% oxygen, it takes a long time to recover. The half-life on 100% non-rebreather is about 90 minutes. So they can kind of be on this for, several hours in a row, kind of an overnight hospital stay, and usually do very well after that. If they're bad enough, you can put them on hyperbaric, and then that cuts the time, the half-life to about 30 minutes. So usually they can be in the hyperbaric for just a few hours, and it resolves much quicker. The plan is to treat until the carbon monoxide level is less than 5%. And then one thing that you may hear a provider say is that to let them be a little acidotic, which sounds counterintuitive, but it does shift the curve to the right and actually allows some more of that oxygen that's not being released by the hemoglobin to get released into the tissues, which may help temporarily. So reasons for hyperbaric oxygen. So things to consider whenever you're calling into a hospital. If frequently happened to us in my previous institution, we would call if we knew a level or if we had enough concern, we would actually defer to the adult hospital who had hyperbaric oxygen, and we would let them do that. It is kind of you have to kind of balance everything because they can't be too sick when they're in there. And so you have to kind of have the right patient for it. But pretty much indications are a level over 25%. And again, they usually have moderate headache, change in respirations, and or drowsiness. Any altered mental status should definitely be considered for hyperbaric if they're stable enough for it. The level drops down to 20% in pregnancy, like we talked about, because the fetal hemoglobin binds it more readily. And any loss of consciousness, any severe acidosis, any evidence of in-organ ischemia. So all this, the same thing we talked about, EKG changes, any chest pain, any altered mental status. Ideally, like to start within 6 hours. Studies show that it's not as helpful if it's more than 12 hours. And same thing can if the patient is too sick. So kind of the course for the case number 2, this is actually a patient I saw in the ER in fellowship. And so kind of recap, she was an 11-year-old female with carbon monoxide poisoning. She had decreased altered mental status and vomiting. She was intubated with ketamine and rock, was stable for about 30 minutes. Then she had onset of persistent hypotension despite fluids, and she had an acute drop of her oxygen to 50s despite bagging. Lung sounds were absent on the right, so we proceeded with a needle decompression for a possible tension pneumothorax, and we did get air aspirated out of that right side. So something definitely to consider for you guys in the field. If this does happen, you can get tension pneumo. So I was going to refresh this just because it's something that you guys may do occasionally. And the goal is to position the patient upright, 45 degrees upright if you can. And choose your space, the second intercostal space, the midclavicular line, and the fourth intercostal space, mid-axillary line. Remember, just over the rib. Some even recommend kind of pulling the skin down a little bit, just over the rib, because all of the nerve and vascular bundle is just under the rib, so you want to avoid that. So kind of the actual procedure, make sure you prep your site so we don't induce bacteria into the skin. You can insert the angiocath. The standard is about 1.5 inches at a 90-degree angle to the chest wall. The reason for that is anything less than 1.5 inches can not be successful because the skin or the tissue is too thick. And then you can remove the needle from the cath and leave it in the pleural space. And then chest tube for us, but you guys wouldn't be doing that in the field. I do have a little video, just kind of, I'm a visual learner, and so I feel like it's good to
generally greater than is as successful as a chest tube in relieving a tension pneumothorax, and that the therapeutic benefit persists for at least 4 hours. Recent studies conclude that chest wall thickness is generally greater than previously thought. A study published in Prehospital Emergency Care measured chest wall depth on CT scans and found that needle decompression with a standard 1 3/4 inch angiocatheter would be unsuccessful in 50% of trauma patients on the basis of body habitus. In a study published in the Journal of Trauma, it was found that a 2-inch needle may not penetrate the anterior chest wall of up to 35.4% of the population, depending on age and gender. A study in military medicine recommended that the procedure for needle thoracentesis to relieve tension pneumothorax should be performed with a needle of sufficient length, and that a 3 1/4 inch needle would have reached the pleural space in 99% of the subjects studied. A presumptive diagnosis of tension pneumothorax should be made when progressive respiratory distress develops in the setting of torso trauma. In tactical environments, one should not rely on such typical clinical signs as decreased breath sounds, tracheal deviation, or hyperresonance to percussion, because these signs may not always be present, and even if they are, they may be exceedingly difficult to appreciate in a tactical environment.
And then this was left over from us speaking to the fellow, so we don't have to go on this unless you guys want to, but it's for a pigtail chest tube, and so you guys won't have to worry about that. And actually, this kind of follow up on this patient. So actually did need a norepidural for persistent hypotension. Placed a femoral line, transferred to the PICU. She had shock, multi-organ dysfunction, secondary to carbon monoxide poisoning. At one point, she was on a high frequency, an oscillator ventilator and 2 pressors. Shock liver, severely depressed left ventricular function, and required milrinone. But kind of like we talked about, most patients do very well. And even though she looked very, very sick, she actually improved very quickly and was extubated within about 48 hours and discharged from home at hospital day 6 at baseline. So she did very, very well. So in conclusion, just basically be alert for any airway burns, intubate early when there's any concern. Early treatment should be directed at removing jewelry, clothing, and correctly estimating the total body surface area. So basically, so we can estimate appropriate fluid management and inbound preparations. Keep burns covered, prevent insensible fluid losses and hypothermia, especially in your very little kids. Very common to present cold and dry. And then treat early for any suspected cyanide or carbon monoxide toxicity. And that's about it. Same thing I like seeing with the big picture. This is a big hike in Zion National Park. Kind of Angel's Landing is over here, but if you walk up here, it's actually a better view. But I'm definitely open for any questions that you guys have. Please feel free to type them out or yell them out at me.
Awesome job, Nate. That was great. You've been to a lot of fun places, so that's really cool. I really loved the cases. EMS loves cases and case studies, and that's, so we really appreciate you doing it and highlighting all that information through the cases. I thought that was really awesome. I did see there was one question, and I was going to stop you way back, but I didn't want to interrupt you, but somebody asked about racemic epi, and that would be indicated for any of the airway swelling issues for inhalation.
Yeah, I didn't see it when I was looking up doing my presentation, but it definitely would be reasonable. Again, for that kind of reduce the swelling, reduce the spasm of the airway. It would definitely be worth a shot, and I think not going to be harmful to most children. So if you think about it, and it'd be reasonable to try. Right.
Any other questions? Feel free to type them in, or y'all can always reach out to me, and I can get them to Nate and get them back to you if y'all have them or think of something that comes up. So thank you so much. That was awesome. We really appreciate you taking the time to share your expertise with our EMS partners, and they appreciate it. So thank you.
All right. Thank you, guys.
Awesome, guys. So we're going to post the link to get the eval. And so there is the link for the eval. Click on that and you can get to your eval link. You can also scan this QR code that's going to be on your screen right now if you're on your phone, and do it from there. Or you can always email me and I can forward you the link as well. So 3 options to do it to get your credit. So we're going to leave that up for a little bit. If you'll have any questions, feel free to reach out. And we will look forward to seeing you next month. Thank y'all for everything that you do out there on the front lines. We really appreciate you, and we want to be a resource for you. So let us know how we can do that, and reach out with any questions. Be safe out there and have a great weekend. Thank you.